Yeah, so I will start my presentation now. Good morning, everyone. I'm V, a master student of international program in oral biology, Faculty of Dentistry, Chulalongkorn University. And my advisor is Associate Professor Dr. Risa Suparas. And my co-advisor is Dr. Associate Professor Dr. Niraja Sanjavankit. Today, I would like to present some findings in my study with the topic medication-related osteonecrosis of the jaw, histological comparisons with osteoradionecrosis of the jaw and osteomyelitis of the jaw. The outline of this presentation include introductions, research objective, material and methods, results and discussion, and finally the conclusions. Now, I would like to introduce about the background and rationale of my presentations. As we know, medication-related osteonecrosis of the jaw, MRONJs, is an adverse side effect of agents used to manage skeletal disease, such as osteoporosis, multiple myeloma, or bone metastasis. MRONJs were first reported in 2003 by Robert Marks as a serious side effect of bifosfonate. After that, many drugs were reported to relate to this disease, so it was renamed medication-related osteonecrosis of the jaw. So, what is the definitions of MRONJs? MRONJs were clinical manifest as exposed bone has persisted for more than 8 weeks without history of radiation exposure to the head and neck area. Not only MRONJ show exposed jaw bones, osteoradionecrosis of the jaw, ORNs, is defined as exposed irradiated bone that failed to heal over a period of 3 months without evidence of persisting or recurrent tumor. Another common disease shown exposed jaw bone is osteomyelitis of the jaw, which is defined as an infection of bone usually induced by polymicrobial odontogenic infections. These three kinds of disease share the similarity in clinical characteristic and radiographic image, despite difference in cause and pathophysiology. So it's necessary to investigate their histological profile to understand about the pathogenesis of MRONJs. Moreover, a histological investigations is a powerful tool to understand have a broad view and basic knowledge of the pathogenesis. Therefore, the research objective of this study is to evaluate and describe the histological feature of MRONJs, and then compare the histological characteristic of MRONJ with OM, ORN, and the control group. Next, we move on to the detail of material and methods. For sample selections, the patients have to meet the clinical criteria at least in this table. For example, with MRONJs, patients have to show an evidence of exposed and devitalized jaw bones, history of anti-resorptive or anti-angiogenic agent therapy without history of radiation exposure. For ORN, patients have to show an evidence of exposed and devitalized jaw bones, history of radiation exposure, but show no document histories of anti-resorptive or anti-angiogenic agent therapies. For osteomyelitis patients have to show a sign and symptom of inflammation in jaw bones, such as pain, swelling, discharge, or tenderness. And with the control group, the patients show no any evidence of evidence, at least in this table. Moreover, the demographic information as well as clinical characteristic or radiographic feature of patients also collected from biopsy report. After case review, histologic examinations were performed. In histological parameter, we observe the hard tissue, soft tissue, inflammatory cells, and bacterial colony. In heart tissue, the bone cells such as osteocyte, osteoblast, and osteoclast, and the peripheral resorptions were evaluated. In soft tissue, the presence of granulation tissue and fibrotic tissue were observed, and inflammatory cells include plasma cell, lymphocyte, or neutrophil, as well as bacterial colony were also a trial interest in this study. Next, we go to the results and discussion. Overall, there are 57 samples from the study, including 17 samples from MRONJs, 15 samples from ON and OM, and 10 samples from the control group. Overall, almost sample collected from mandible jawbones. And overall, the patients have a difference in demographic information such as sex and age. The information collected from our study not quite similar when compared with other previous study in the almost the same aspect. So it may lead into the difference in the results. In general, histology of MRONJ or NOM are quite similar. It is presence of necrotic bone, which characteristic as empty lacunae, and we can see here, and lack of osteoplastic rimming. Here is the 40 multiply magnifications, and we can see here in the picture. For detail of evaluate the heart tissue, we observe that the presence of necrotic bone present in 100% case of MRONJs and ORNs, 86% case of OM, and the control group show no evidence of necrotic bone. There were a significant difference in the presence of necrotic bone, the present osteoblast, and peripheral resorptions in the necrotic disease group compared with the control group. However, the presence of osteoclast show no significant difference when compared between the necrotic group and the control group. When evaluate soft tissue, and we can see here is the classic image of soft tissue of each disease. And we found that there were a significant difference in the presence of granulation tissue between MRONJs and the control group. Inflammatory infiltrations were also significantly increased in MRONJs and other necrotic group when compared with the control group. However, there were no significant difference when we observed the inflammations among the necrotic disease. Moreover, the presence of fibrotic tissue increased significantly higher in the ORN group when compared with other. This finding suggests that support the theory radiations induce fibrosis to damage the normal tissue. When observed the presence of bacterial colony, we also observed that MRONJ specimen exhibit a loss of dense bacterial cluster. Here, as we can see here, found in the bone peripheries, where a spare bacterial colony were observed to locate within marrow bone space of Osteomyelitis specimens. When we analyze with the statistic analysis, we also found a significant difference in when compare MRONJs and the OM group, but not with the ORNs. And here we can see in the picture, it's almost they show the same presence of bacterial colony in MRONJs and ORN, but not OM and the normal jawbone. Although the present osteoclast show no any significant difference when compare the MRONJs and another group. However, osteoclast still not worthy because it is the cell directly affected by medications in MRONJs. It was broadly believed that osteoclasts were induced apoptosis in mRNAs. In this study, we also observed an image of dispersed nuclei into cytoplasm and loss of peripheral border of osteoclast, as well as image of empty house-shaped lacunae were observed in most of specimens of mRNAs. All these findings confirm the apoptosis process in mRNAs. However, the frequency of osteoclast encounter does not change significantly, suggests that osteoclast might again the effect of medication in the osteoclast apoptosis and somehow persisted. More interestingly, many osteoclasts of mRNAs were not with triangle shape comparing with small osteoclast normally found in other group, as we can see here in the picture. And when we evaluate the associations between osteoclasts and other covariates, especially osteoblast cell, we found that there were significant associations between osteoblast and osteoclast. So maybe osteoclast play an important role in the response of osteoclast in mRNAs. In conclusions, mRNAs is characterized by necrotic bond with peripheral resorption showing irregular shape and the presence of dense bacterial cluster on the bone surface, and giant osteoclast is the highlighted feature of mRNA. Thank you for your listening. If you have any questions, please feel free to ask. I will try my best to answer your questions.
Thank you so much for your presentations. Well, we're going to see the question from the audience. Okay, so this is not coming yet, so going to be a question from me.
Yeah.
Well, from your results, do you think that these three conditions can be different solely by using history?
Yeah, sure. At this time, we almost depends on the histories of patients to diagnose this kind of disease. But actually, I want to focus on like the mechanism of the three of disease, because mRNAs and will not have quite understanding mechanism. So if we focus on the histology, we might find something good, something good to evaluate, to understand the mechanism. Yeah, but yes, depends on history. Yeah, we can. Yeah, but actually, because the patient, like they have the cancer, maybe they not only have one treatment like pifophonas or only the drugs. They may have the radiation treatment. So maybe it's really hard to have a good therapy. So if we understand like the mechanism of this disease, we might have a better and the best therapy for patients in the future.
So from your results so far, did you can you conclude for us which mechanism that you thought it might be, or which cells related?
Yeah, in my literature reviews, there are many proposed hypotheses about the mechanism of mRNAs, but in this research, I focus on the effect of the response of osteoclast cell by mRNA. So I think it might relate to the response and the reactions of these cells to the drug. And if we focus on observe the mechanism of these cells, we might found something new. So yeah, but actually a lot of research, they focus on the inflammation pathway or the presence of bacterial colony, so it might affect the results. And as we know, like in the human body, it's really complicated because have many factors to play the role and affect each other. So we have to see the disease in the full picture.
There's a question from audience. In your opinion, could there be any difference in histology of bone of Imralonje between patients? Only on anti-resorptive agents and only on anti-angiogenic agents. Okay.
So the other means what is different between the histologies of anti-angiogenic therapy and anti-resorptive therapy, right?
Yes.
Actually, not just observed in the mRNAs. The histologies of mRNAs, ORN and OM was quite similar and we cannot diagnose. It just depends on the histologies of observed the hard tissue, on soft tissue only. So yeah, if in my point of view, it's impossible to separate to diagnosis between this kind of this. So we have to depends on another technique like immunohistochemistry. If you know exactly the specific protein is spread in, and it still continue to research maybe in the future, but not now. So yeah, we just depend on the histories of patients, not histology now.
So do you have any explanations about the appearance of giant cells, which is larger in mRNA? Is it anything that could make it happen?
Yes, I have some hypotheses and I keep continuing on my research about this because the giant cell, maybe because of cell-cell fusions, because the osteoclast want to be a giant osteoclast, be cell-cell fusions of mononuclear cell to be a lecture. But when I review the literature, have one study about the cell-cell fusions, they observed the increase of cell-cell fusions in osteoclast mRNAs. However, the cell-cell fusion also increased in ORN2. And they said that the only cell-cell fusion cannot use to explain for the abnormality giant cell in osteoclast. So I hypothesize that maybe because the osteoclast be bigger because they live longer and maybe like they try to against the effect of medication to induce the apoptosis. So maybe if we check it because of the proteins of growth survival signaling proteins such as BCL2 or BCL-XL. And when I investigate when I review the literature, I found that many studies show that the osteoclast operate the expressions of growth survival signaling such as MCL1 or BCL2 and BCL-XL. Actually, this study just did an experiment on animal, so I'm not quite sure on human is it the same mechanism or not. So yeah, it is my study in the future to check if it's expressions or not.
Thank you so much for your clear answer. Okay, thank you.
Thank you.